everyone and welcome to today's lecture. The topic that I'll be dealing today is substance abuse. My topic will be covering 16 objectives which are Introduction to Substance Abuse, Pattern of Substance Use Disorder, Causes of Substance Abuse, Alcohol Use Disorders, Opioid Use Disorders, Cannabis Use Disorder, Cocaine Use Disorder, Amphetamine Use Disorder, LSD Use Disorder, barbiturates use disorder, benzodiazepines and other sedative hypnotics, inhalants or volatile solvent use disorder, phenylcyclidine use disorder, caffeine and nicotine, and signs and symptoms of substance abuse. So, let us begin with the introduction part. Since the primordial times, humans have used several substances in the expectation of reducing physical pain or altering substances of consciousness. Nearly every human society has discovered at least one such substance, natural or artificial, which has been used ceremoniously or recreationally. Many animals also like to get chemically high. Baboons ingest tobacco. Elephants love alcohol. Reindeers and rabbits try to find out hallucinogenic mushrooms. Today, children are experimenting with drugs quite early in life. World Health Organization estimated that globally, 25 to 90% of street children indulge in substance abuse. There are more than 5 lakh street children in India who live and work in inhumane conditions and are at a high risk of substance abuse. And this number could be drastic underestimation. People pursue drug abuse due to a variety of reasons like insecurities or wish to fit to a group. The drug is defined by WHO as any substance that, when taken into the living organism, may modify one or more of its functions. This definition conceptualizes drug in a very broad way, including not only the medications but also the other pharmacologically active substances. A psychoactive drug is one that can alter the mental functioning. The major dependence producing drugs are alcohol, opioids, example opium, heroin. Third is cannabinoids, example cannabis. Fourth is cocaine. Fifth is amphetamine and other sympathomimetics. Sixth is hallucinogens, example LSD, phencyclidine, PCP. Seventh, sedatives and hypnotics, example barbiturates. Eighth, inhalants, example volatile solvents. 9. Nicotine and other stimulants, example caffeine. There are 3 patterns of substance use disorder which may overlap with each other. First, acute intoxication. Second, withdrawal state and dependence syndrome. Coming to acute intoxication. Acute intoxication is a transient condition following the administration of alcohol or other psychoactive substance resulting in disturbances in level of consciousness, cognition, perception, affect or behavior or other psychophysiological functions and responses. This is usually associated with high blood levels of the drug. However, in certain cases where the threshold is low due to serious medical illness, even a low dose may lead to intoxication. The intensity of intoxication lessens with time and effects eventually disappear in the absence of further use of the substance. The recovery is therefore complete except where tissue damage or another complication has arisen. Second one is withdrawal state. A withdrawal state is characterized by a cluster of symptoms often specific to the drug used which develop on total or partial withdrawal of a drug, usually after repeated and or high dose use. This too is a short-lasting syndrome with usual duration of few hours or to few days. Typically, the patient reports that the withdrawal symptoms are relieved by further substance use. Now coming to the third one, that is dependence syndrome. The dependence syndrome is a cluster of physiological, behavioral, and cognitive phenomena in which the use of a substance or class of substance takes on much higher priority for a given individual than other behaviors that once had greater value. A central descriptive characteristic of dependence syndrome is the desire, often strong and sometimes overpowering, to take psychoactive substances which may or may not have been medically prescribed, alcohol or tobacco. There may be evidence that return to substance use after a period of abstinence leads to a more rapid reappearance of other features of syndrome than occurs with non-dependent individuals. An individual is said to be drug dependent if he or she has experienced at least three of the following. First, a strong desire or sense of compulsion to take the substance. Second, difficulties in controlling the substance taking behavior in terms of its onset, termination, or levels of use. Third, physiological withdrawal state when the substance use has ceased or reduced as evidenced by the characteristic withdrawal syndrome for the substance or use of the same substance with the intention of relieving or avoiding withdrawal symptoms. Fourth, evidence of tolerance such that increased doses of psychoactive substance are required to achieve effects originally produced by lower doses. Clear examples of this are found in the alcohol and opiate dependent individuals who may take daily doses that are sufficient to incapacitate or kill non-tolerant users. Fifth, progressive neglect of alternative pleasures or interests because of psychoactive substance use. Increased amount of the time necessary to obtain or take the substance or to recover from its effects. Sixth, persisting with the substance use despite clear evidence of overtly harmful consequences such as harm to the liver through excessive drinking, depressive mood states, consequent to periods of heavy substance use or drug-related impairment of cognitive functioning. Efforts should be made to determine that the user was or could be expected to be aware of the nature and extent of the harm. Now coming to the next portion, that is causes of substance abuse. First one is biological factors. It includes genetic vulnerability and comorbidity. So, genetic vulnerability. One of the major causes of drug dependence is that people may inherit an increased likelihood of developing dependence. Family studies of alcohol use disorders suggest that such disorders do cluster in families. Comorbidity. When two disorders or illnesses occur in the same person simultaneously or sequentially, they are described as comorbid. Comorbidity also implies interactions between the illnesses that affect the course and prognosis of both. Many people who regularly abuse drugs are also diagnosed with mental disorders and vice versa. Psychological factors. Most of the people experiment with drugs out of curiosity, need for novelty, to show rebelliousness, and social non-conformity. Many individuals have poor impulse control, low self-esteem, that is enemy, concerns regarding the personal autonomy or poor stress management skills. Research has further pointed towards childhood trauma or loss. Social factors. Apart from biological and psychological factors, many social factors like peer pressure, modeling, ease of availability of alcohol and drugs, intrafamilial conflicts, religious reasons, poor social or familial support are responsible for substance abuse. Now coming to some of disorders. First one is alcohol use disorder. Alcohol dependence was previously called as alcoholism. This term, much like addiction, has been dropped due to its derogatory meaning. According to Jelinek, there are 5 species of alcohol dependence based on the patterns of use and not based on the severity. First is alpha. Excessive and inappropriate drinking to relieve physical and emotional pain. There is no loss of control and the user has the ability to abstain. Second is beta. Excessive and inappropriate drinking which leads to physical complications, for example, cirrhosis and gastritis. Due to cultural drinking patterns and poor nutrition, there is no dependence. Third one is gamma. It is also called as malignant alcoholism. The drinker has physical dependence with tolerance and withdrawal symptoms as well as psychological dependence with inability to control drinking. Fourth, delta. There is inability to abstain. Tolerance and withdrawal symptoms are present. Social disruptions is minimal. Fifth, epsilon. The drinker goes on spree drinking, tolerance and withdrawal syndrome is present, the person in epsilon stage is compulsive drinker, that is dipsomania. Collinger in 1987 has classified alcoholism in two types on the basis of relative importance of genetic and environmental factors. Alcohol dependence is more common in males and has an onset in late second or early third decade. The course is usually insidious. There is often an associated abuse or dependence of other drugs. If the onset occurs late in life, especially after 40 years of age, there is an underlying mood disorder. After consuming alcohol, there is a brief period of excitation wherein there is a generalized central nervous system depression. With increasing intoxication, there is increased reaction time, slow thinking, distractibility, and poor motor control. Later, dysarthria, that is slurred speech, ataxia, lack of muscle coordination can occur. There is progressive loss of self-control with frank disinhibited behavior. Occasionally, a small dose of alcohol may produce acute intoxication in some persons. This is known as pathological intoxication. Another feature sometimes seen is acute intoxication is the development of amnesia or blackouts. The most common withdrawal syndrome is hangover on the next morning. Mild tremors, nausea, vomiting, weakness, irritability, insomnia and anxiety are the common withdrawal symptoms. Sometimes the withdrawal syndrome may be more severe, characterized by one of the following three disturbances: delirium tremens, alcoholic seizures, and alcoholic hallucinosis. It is important to remember that alcohol withdrawal syndrome can be associated with marked morbidity as well as significant mortality, and it is important to treat it correctly. First one is delirium tremens. Delirium tremens is the most severe alcohol withdrawal syndrome. It occurs usually within 2 to 4 days of complete or significant abstinence from heavy alcohol drinking in about 5% of patients as compared to acute tremulousness which occurs in about 34% of patients. The course is short with recovery occurring within 3 to 7 days. The characteristic feature of an acute organic brain syndrome, delirium, are: first, clouding of consciousness with disorientation in time and place. Second, poor attention span and distractibility. Third, visual and auditory hallucinations and illusions which are often vivid and very frightening. Tactile hallucinations of insects crawling over the body may occur. Fourth, marked autonomic disturbance with tachycardia, fever, hypertension, sweating and pupillary dilation. Fifth, psychomotor agitation and ataxia. Sixth, insomnia with reversal of sleep-wake pattern. Seventh, dehydration with electrolyte imbalance. Death can occur in 5 to 10% of patients with delirium tremens and is often due to cardiovascular collapse, infection, hyperthermia, or self-inflicted injury. At times, the intercurrent medical illnesses such as pneumonia, fractures, liver diseases, or pulmonary tuberculosis may complicate the clinical picture. Second one is alcohol hallucinosis. Alcohol hallucinosis is characterized by the presence of hallucinations, usually auditory, during partial or complete abstinence following the regular intake. It occurs in about 2% of patients. These hallucinations persist after the withdrawal syndrome is over and classically occur in clear consciousness. Usually recovery occurs within 1 month and the duration is very rarely more than 6 months. There are many complications arising from alcoholism like fatty liver, cirrhosis of liver, hepatitis, liver cell carcinoma, liver failure, delirium tremens, alcohol hallucinosis, Wernicke-Korsakoff psychosis, alcohol dementia, suicide, cerebellar degeneration. Apart from medical complications, there are many social complications that it follows like accidents, marital disharmony, divorce, occupational problems with loss of productive man hours, increased incidence of drug dependence, criminality, financial difficulties. Now coming to opioid use disorder. Dried exudate obtained from unripe seed capsules of Papaver somniferum has been used and abused for centuries. The natural alkaloids of opium and their synthetic preparations are highly dependence producing. A. Natural alkaloids of opium, morphine, codeine, thebine, coscapine and papaverine. B. Synthetic compounds, heroin, nalorphine, hydromorphone, methadone, dexatropoxyphene, meperidine, levorofan and diphenozylate. In the last few decades, use of opioids has increased markedly all over the world. India, surrounded on both sides by the infamous routes of illicit transport, namely Golden Triangle, Burma-Thailand Laos and the Golden Crescent, Iran, Afghanistan, Pakistan, has been particularly severely affected. The most important dependence-producing deprivatives are morphine and heroin. Heroin is more addicting than morphine and can cause dependence even after a short period of exposure. Tolerance to heroin occurs rapidly and can be increased to up to more than 100 times the first dose needed to produce an effect. Intoxication is characterized by apathy, hypotension, respiratory depression, subnormal core body temperature, and pinpoint pupils. Later, delayed reflexes, unsteady pulse, and coma may occur in case of large overdose. In severe intoxication, mydriasis may occur due to hypoxia. The onset of withdrawal symptoms occurs typically within 12 to 24 hours, peaks within 24 to 72 hours, and symptoms usually subside within 7 to 10 days of the last dose of opioid. The characteristic symptoms include lacrimation, pupillary dilation, sweating, diarrhea, yawning, tachycardia, mild hypertension, insomnia, raised body temperature, muscle cramps, generalized body ache, severe anxiety, piloerection, nausea, and vomiting. There are marked individual differences in presentation of withdrawal symptoms. Heroin withdrawal syndrome is far more severe than the withdrawal syndrome seen with morphine. The complications of chronic opioid use may include Parkinsonism, degeneration of globus pallidus, peripheral neuropathy, transverse myelitis. Complications can also arise due to intravenous use as AIDS, skin infections, pulmonary embolism, septicemia, viral hepatitis, and tetanus. Now coming to cannabis use disorder. is derived from the hemp plant Cannabis sativa, which has several varieties named after the region in which it is found. Example, Sativa indica in India and Pakistan and Americana in America. Cannabis produces more than 400 identifiable chemicals, of which about 50 are cannabinoids, the most active being delta-9 tetrahydrocannabinol, that is delta-9 THC. Cannabis produces a very mild physical dependence with a relatively mild withdrawal syndrome, which is characterized by fine tremors, irritability, restlessness, nervousness, insomnia, decreased appetite, and cravings. This syndrome begins within few hours of stopping cannabis use and lasts for 4 to 5 days. On the other hand, psychological dependence ranges from mild, occasional trips to marked, compulsive use. Mild cannabis intoxication is characterized by mild impairment of consciousness and orientation, lightheadedness, tachycardia, a sense or floating in the air, a euphoric dream-like state, alternation, either an increase or decrease in psychomotor activity and tremors, in addition to photophobia, lacrimation, tachycardia, reddening of conjunctiva, dry mouth and increased appetite. There is often a curious splitting of consciousness in which the user seems to observe his own intoxication as a non-participant observer, along with a feeling that time is slowed down. Perceptual disturbances are common and can include depersonalization, derealization, synesthesias, a sensation in which a sensory modality caused by sensation in another sensory modality, example, seeing the music. However, hallucinations are seen only in marked to severe intoxication. These are often visual, ranging from elementary flashes of lights and geometrical figures to complex human faces and pictures. Mild cannabis intoxication releases inhibitions, which is expressed in words and emotions rather than in actions. Flashback phenomenon has been described and is characterized by recurrence of cannabis use experience in the absence of current cannabis use. The complications of cannabis use can include transient or short-lasting psychiatric disorders, acute anxiety, paranoid psychosis, hysterical fugue-like states, suicidal ideation, hypomania, schizophrenia-like state, which is characterized by persecutory delusions, hallucinations, and at times catatonic symptoms. Other complications like memory impairment, worsening or relapse in schizophrenia or mood disorder, chronic obstructive airway disease, pulmonary meningitis. Cocaine use disorder. Cocaine is an alkaloid derived from coca bush, Erythroxylum coca, found in Bolivia and Peru. It was isolated by Albert Neyman in 1860 and was used by Carl Kohler, a friend to Freud, in 1884 as the first effective local anesthetic agent. Cocaine, common street name crack, can be administered orally, intranasally, by smoking, and freebasing or parenterally depending on the preparation available. Cocaine, HCI, is the commonest form used, followed by the free-based alkaloid. Both intravenous use and free-based inhalation produce a rush of pleasurable sensations. Cocaine is a central stimulant which inhibits the reuptake of dopamine along with the reuptake of norepinephrine and serotonin. In animals, the cocaine is the most powerful reinforcer of drug-taking behavior. A typical pattern of cocaine use is cocaine runs, binges, followed by cocaine crashes, interruption of use. Cocaine is sometimes used in combination with opiates like heroin, speedball, or at times amphetamines. Previously, uncommon cocaine misuse appears to be recently a growing problem in the metros of India. Acute cocaine intoxication is characterized by pupillary dilation, tachycardia, hypertension, sweating, and nausea or vomiting. A hypomanic picture with increased psychomotor activity, grandiosity, elation of mood, hypervigilance, and increased speech output may be present. Later, judgment is impaired and there is impairment of occupational functioning. Cocaine use produces a very mild physical but a very strong psychological dependence. A triphasic withdrawal syndrome usually follows an abrupt discontinuation of chronic cocaine use. The complications of chronic cocaine use include acute anxiety, reaction, uncontrolled compulsive behavior, psychotic episodes, delirium, and delusional disorder. High doses of cocaine can often lead to seizures, respiratory depression, coronary artery occlusion, myocardial infarction, lung damage, gastrointestinal necrosis. Now coming to amphetamine use disorder. Though synthesized by Adliano in 1887, it was introduced in medicine in 1932 as benzedrine inhaler for the treatment of coryza, rhinitis and asthma. Later, it was recommended for a variety of conditions such as narcolepsy, post-encephalitic Parkinsonism, obesity, depression, and even to heighten energy and capacity to work. Amphetamine refers a unique chemical which is basically phenylisopropylamine or methylphenylthalamine. It is a powerful CNS stimulant with peripheral sympathomimetic effects too. It acts primarily on norepinephrine release in brain along with an action of the release of dopamine and serotonin. Although still clinically indicated for narcolepsy and attention deficit hyperactivity disorder, one of the commonest patterns of use is seen amongst the students and sportspersons to overcome the need for sleep and fatigue. Tolerance usually develops to the central as well as cardiovascular effects of amphetamines. The signs and the symptoms of acute amphetamine intoxication are primarily cardiovascular, tachycardia, hypertension, hemorrhage, cardiac failure, and cardiovascular shock, and central, which includes seizures, hyperpyrexia, tremors, ataxia, euphoria, pupillary dilation, tetany, and coma. The neuropsychiatric manifestations include anxiety, panic, insomnia, restlessness, irritability, hostility, and bruxism. Acute intoxication may present as a paranoid hallucinatory syndrome, which usually mimics paranoid schizophrenia. The distinguishing features include rapidity of onset, prominence of visual hallucinations, absence of thought disorder, appropriateness of effect, fearful emotional reaction, and presence of confusion. Chronic amphetamine intoxication leads to severe and compulsive craving for the drug. A high degree of tolerance is characteristic with the dependent individual needing up to 15 to 20 times the initial dose to obtain the pleasurable effects. A common pattern of chronic use is a cycle of runs, heavy use for several days, followed by crashes, that is stopping the drug use. Tactile hallucinations in clear consciousness may sometimes occur in chronic amphetamine intoxication. The withdrawal syndrome is typically seen on an abrupt discontinuation of amphetamines after a period of chronic use. The syndrome is characterized by depression, may present with suicidal ideation, marked asthenia, apathy, fatigue, hypersomnia, alternating with insomnia, and agitation. Coming to LSD use disorder. Lysergic and diethylamide, first synthesized by Albert Hofmann in 1938 and popularly known as acid, is a powerful hallucinogen. It is related to the psychedelic compounds found in the morning glory seeds, the lysergic acid amides. As little as 100 mg of LSD is sufficient to produce behavioral effects in man. LSD presumably produces its effects by an action on the serotonin levels in the brain. Although tolerance as well as psychological dependence can occur with LSD use, no physical dependence or withdrawal syndrome is reported. A common pattern of LSD use is a trip, occasional use followed by a long period of abstinence. The characteristic feature of acute LSD intoxication are perceptual changes occurring in a clear consciousness. These perceptual changes include depersonalization, derealization, intensification of perception, synesthesis, for example, colors are heard and sounds are felt, illusions and hallucinations. In addition, features suggestive of autonomic hyperactivity such as pupillary dilation, tachycardia, sweating, tremors, incoordination, palpitations, raised temperature and giddiness can also be present. These changes are usually associated with marked anxiety and or depression, though euphoria is more common in small doses. Persecutory and referential ideation may also occur. Sometimes, acute LSD intoxication presents with an acute panic reaction known as bad trip, in which the individual experiences a loss of control over his self. The recovery usually occurs 8 to 12 hours of the last dose. Rarely, the intoxication is severe enough to produce an acute psychotic episode resembling a schizophrenia from psychosis. No withdrawal from syndrome has been described with LSD use. However, sometimes there is a spontaneous recurrence of the LSD use experience in a drug-free state. Described as a flashback, it usually occurs weeks to months after the last experience. Such episodes are often induced by stress, fatigue, alcohol intake, severe physical illness, or marijuana intoxication. The complications of chronic LSD use include psychiatric symptoms such as anxiety, depression, psychosis, or visual hallucinosis, and occasionally fetal abnormalities. Now, barbiturate use disorder. Barbiturate use disorder is now subsumed under sedative, hypnotic, and anxiolytic use disorders. However, it has been described separately as it has some distinctive feature. Since their introduction in 1903, barbiturates have been used as sedatives, hypnotics, anticonvulsants, anesthetics, and tranquilizers. Commonly abused barbiturates are secobarbital, pentobarbital, and amobarbital. Their use has recently decreased markedly as benzodiazepines have replaced barbiturates in most of their clinical uses. Barbiturates produced marked physical and psychological dependence. Tolerance, both central and metabolic, develops rapidly and is usually marked. There is also a cross-tolerance with alcohol. Acute intoxication, typically occurring as an episodic phenomenon, is characterized by irritability, increased productivity of speech, lability of mood, disinhibited behavior, slurring of speech, incoordination, attentional and memory impairment, and ataxia. Mild barbiturate intoxication resembles alcohol intoxication. Severe forms are present with diplopia, nystagmus, hypotonia, and suicidal ideation. Drug automatism may sometimes lead to lethal accidents. Intravenous use can lead to skin abscesses, cellulitis, infections, embolism, and hypersensitivity reactions. The barbiturate withdrawal syndrome can be very severe. It is usually characterized by marked restlessness, tremors, hypertension, seizures, and in severe cases, a psychosis resembling delirium tremens. The withdrawal syndrome is at its worst about 72 hours after the last dose. Coma followed by death can occur in some cases. Now, benzodiazepines and other sedative hypnotics. Since the discovery of chlordiazepoxide in 1957 by Sternbach, benzodiazepines have replaced other sedative hypnotics in treatment of insomnia and anxiety. These are currently one of the most often prescribed drugs. Benzodiazepines produce their effects by acting on the benzodiazepine receptors, GABA, thereby indirectly increasing the action of GABA, the chief inhibitory neurotransmitter in the human brain. Benzodiazepine or sedative hypnotic use disorder can either iatrogenic or originating with illicit drug use. Dependence, both physical and psychological, can occur and tolerance is usually moderate. Acute intoxication resembles alcohol intoxication, whilst chronic intoxication causes tolerance, especially to the sedative and anticonvulsant actions of benzodiazepines. Excessive doses can often lead to respiratory depression, coma, and death, while chronic use has been reported to cause amnestic syndrome. Some of the other implications of benzodiazepines, particularly with high dose and chronic use, include behavioral disinhibition, impulsivity, blackouts, memory loss, worsening of depression, interactions with other prescribed medications. A typical withdrawal syndrome after cessation of prolonged use, more than 4 to 6 weeks of moderate to heavy doses, more than 60 to 80 mg per day of diazepam, is characterized by marked anxiety, irritability, tremors, insomnia, vomiting, weakness, autonomic hyperactivity with postural hypotension, and seizures. Depression, transient psychotic episodes, suicidal ideation, perceptual disturbances, and rarely delirium have also been reported in withdrawal period. Now, coming to Ilhanen's or volatile solvent use disorder. The commonly used volatile solvents include gasoline, petrol, glues, aerosols, spray paints, thinners, varnish remover, and industrial solvents. The active ingredients usually include benzene, acetone, and halogenated hydrocarbons. Volatile solvent misuse is more commonly in early adolescence as a group activity, particularly in low socioeconomic status groups. For example, rag pickers in Mumbai and Delhi. Inhalation of volatile solvent leads to euphoria, excitement, belligerence, dizziness, slurring of speech, apathy, impairment judgment, and neurological signs such as decreased reflexes, ataxia, nystagmus, incoordination, and coma. Death can occur due to respiratory depression. The complications include irreversible damage to liver and kidneys, peripheral neuropathy, perceptual disturbances, and brain damage. There appears to be no specific treatment of the inhalant use disorder. There is often an associated psychiatric disorder, usually schizophrenia, or personality disorder, particularly in solitary sniffers. Or there is a history of criminal background. The prognosis is usually guarded. Now, phencyclidine use disorder. Phencyclidine PCP was introduced as a dissociative anesthetic agent in 1950s. However, its use was soon restricted to veterinary anesthesia as some human subjects developed delirium while emerging from anesthesia. Classified as an atypical hallucinogen, street names peace pill, angel dust. PCP selectively antagonizes the neural action of NMDA, that is N-methyl-D-aspartate. PCP is usually taken either occasionally or in binges called runs. However, some individuals do take PCP in a regular manner. It can be administered orally, intravenously, or by snorting. Acute PCP intoxication produces euphoria in small doses. High doses produce dysphoria, and other features may include impulsiveness, agitation, impaired social judgment, aggression, feeling of numbness, and inability to move. PCP intoxication can sometimes present with psychiatric syndrome, catatonic syndrome, delirium, stupor, paranoid hallucinatory psychosis, mania or depression, and neurological symptoms, that is nystagmus, ataxia, dysarthria, rigidity, seizures, or coma. Although no clear-cut withdrawal syndrome has been described, craving, social withdrawal, anxiety, depression, and impairment in cognitive functions have been reported. Let us now discuss about caffeine and nicotine. Caffeine and nicotine are the most widely used substances as they both are legally available. Both can cause intoxication, dependence, tolerance, and withdrawal syndrome. Nicotine use, often in the form of smoking, is more common in schizophrenia and depression. Smoking predisposes to increased risk of cardiovascular disease, respiratory disease, and cancer can affect metabolism of several psychotropic drugs. Nicotine withdrawal can occur 12 to 14 hours after last smoke and can present with anxiety, restlessness, poor concentration, decreased sleep, increased appetite, and exacerbation of psychiatric symptoms in those with pre-existing psychiatric disorders. Similarly, caffeine is widely used in general population as well as in patients with psychiatric disorders. DSM-5 defines caffeineism, caffeine intoxication, as a recent consumption of caffeine, usually in excess of 250 mg per day, along with the 5 or more of the following: restlessness, nervousness, excitement, insomnia, flushed face, diuresis, gastrointestinal disturbance, muscle twitching, rambling, flow of thought and speech, tachycardia, periods of inexhaustibility, and psychomotor agitation. These symptoms should be accompanied by clinically significant distress or impairment in social, occupational, or other areas of functioning, and the symptoms should not be better accounted by a general medical condition or another mental disorder. The typical content of caffeine in the commonly used drinks is usually as follows: tea 45 mg per cup, instant coffee 60 mg per cup, brewed coffee 100 mg per cup, and cola drinks 25 to 50 mg per can. Caffeine is also present in chocolate. Now, coming to signs and symptoms of substance abuse. Friends and family are among the first to recognize the signs of substance abuse. Early recognition increases the chances for successful treatment. Signs to watch include giving up the past activities such as sports, homework, or hanging out with new friends, declining grades, aggressiveness and irritability, significant change in mood or behavior, forgetfulness, disappearing money or valuables, feeling run down, hopeless, depressed, or even suicidal, sounding selfish and not caring about others, increased use of room deodorizers and incense, physical problems with unclear cause, for example, red eyes and slurred speech, having blackouts forgetting what he or she did the night before, getting in trouble with the law, suspension or other problems at school or in the workplace for an alcohol or drug-related incident. This brings us to the end of the topic. Thanks for watching.